Before answering any business question, we first need to prepare our analytical workspace. We'll begin by creating a pivot table. Click anywhere inside the OPC visits dataset. Next, press Ctrl A and select the entire table. Navigate to the Insert tab and select Pivot Table. A dialog box appears. Before creating the pivot table, make sure you check the option Add this data to the data model. This is a very important step. The data model extends Excel's analytical capabilities and allows us to perform advanced calculations such as distinct counts, which we will need later to determine the number of unique patients attending the hospital. Without the data model, Excel can count records but cannot accurately count unique patients. Next, we select the new worksheet and click OK. Excel creates a dedicated worksheet containing our pivot table. Now we are ready to begin our analysis. Let's begin by understanding the operational performance of the outpatient department. Before we analyze trends or patient behavior, we first need to understand the overall workload handled by the department. The question we are trying to answer is, how many outpatient visits were recorded during the study period? To answer this question, we drag the patient ID into the values area of the pivot table. Click the drop-down arrow beside the patient ID, select value field settings and choose count. Excel now counts every outpatient encounter recorded in the dataset. The analysis reveals that Northbridge Hospital recorded 7,000 outpatient visits. This figure represents the total demand placed on outpatient services. Every one of these visits required clinician time, administrative support, medications, equipment, and infrastructure. For hospital management, this KPI serves as a direct measure of workload and service utilization. Based on this finding, hospital leadership should continuously monitor patient volumes and incorporate them into staffing plans, medication forecasting, and future service expansion decisions. However, total visits only tell part of the story. The next question naturally becomes, were these 7,000 visits generated by 7,000 different people? Or were some patients returning multiple times? To answer this, we need to determine the number of unique patients served by the hospital. Drag the patient ID into the values area once again. Open value field settings and select distinct count. Remember, this option is only available because we added the dataset to the data model earlier. Excel now removes duplicate patient IDs and counts each patient only once. The analysis shows that Northbridge Hospital served 5,019 unique patients. This tells us that while the hospital recorded 7,000 visits, those visits came from approximately 5,000 different individual patients. This KPI measures the hospital's population reach and provides insight into how many individuals benefited from the outpatient services. Now that we know both the total visits and the total number of patients, we can answer an even more interesting question. How often does the average patient return for care? To answer this question, simply divide the total number of visits by the total number of patients. This gives us approximately 1.39 visits per patient. This means the average patient visited the hospital slightly more than once during the study period. For acute illnesses, this may be expected. However, with chronic conditions such as hypertension, diabetes, asthma, and heart disease, higher follow-up rates are generally desirable. A relatively low revisit rate may therefore indicate opportunities to strengthen continuity of care. Northbridge Hospital could improve follow-up attendance through appointment reminders, chronic disease clinics, and structured patient tracking systems. Now that we understand patient attendance at the individual level, let's examine attendance from a broader operational perspective. How busy is the hospital on a typical day or month? To calculate the average monthly attendance, we create a pivot table with the visit month in the rows area and the patient ID in the values area using count. The monthly totals are then averaged. The analysis shows an average of approximately 259 visits per month. This provides a useful benchmark for planning monthly staffing levels, medication procurement, and budget allocation. Hospital managers can use this figure as a baseline for evaluating fluctuations in demand. Next, we want to understand the typical daily workload. Using the total visits and the number of operational days in the dataset, we calculate the average number of visits per day. The result is approximately 8.68 visits per day. This means that on a typical day, the outpatient department manages around 9 patient encounters. This KPI can be used to evaluate workforce productivity and consultation capacity. Now that we have examined overall activity levels, let's explore how patient attendance changes over time. The key question for hospital leadership is whether demand for services is increasing. To answer this, drag VCDA into the rows area and patient ID into the values area as count. Next, navigate to the Pivot Table Analyze tab and select Pivot Chart. Choose a line chart and click OK. Now that Excel has created a chart, let's make it presentation ready. Click the chart title and rename it to the number of OPC visits per year. Next, click the plus sign beside the chart and enable axis titles. Rename the horizontal axis title to year and rename the vertical axis title to the number of visits. Next, enable data labels so that viewers can immediately see the exact number of visits represented by each point on the chart. Finally, right-click anywhere on the chart and select Hide All Field buttons on chart. This removes unnecessary pivot table controls and creates a cleaner, more professional visualization suitable for a dashboard. Once formatting is complete, remove the chart to the dashboard worksheet and resize it appropriately. From 2024 to 2025, the patient attendance increased. This suggests growing utilization of hospital services. The lower value observed in 2026 likely reflects incomplete data collection rather than a true decline in attendance. Overall, the trend indicates increasing demand. Hospital leadership should anticipate continued growth and ensure that staffing, infrastructure, and resources expand accordingly. At this point, we have established that outpatient attendance is increasing over time, but yearly trends only provide a high level overview. To manage hospital operations effectively, we also need to understand how patient attendance fluctuates throughout the year and across different days of the week. Understanding monthly trends helps hospitals anticipate seasonal changes in demand and to allocate resources more effectively. To answer this question, we create a new pivot table. Drag the visit month to the rows area, drag the patient ID into the values area. We open the value field settings and ensure the field is summarized visit count. Next, we insert a pivot chart and select a line chart. Just as we did previously, let's format the chart for presentation. The resulting chart shows fluctuations in attendance throughout the year. Patient visits increase steadily during early months of the year and reach a peak around March. After this peak, attendance declines and then stabilizes during the remainder of the year. This pattern is particularly interesting because seasonal changes often influence disease patterns. Periods of increased attendance may coincide with malaria transmission seasons, respiratory infections, gastrointestinal illnesses, or other public health challenges. For hospital management, these findings are extremely valuable. Rather than reacting to patient surgeries, hospitals can proactively prepare for them. Based on this trend, Northbridge hospitals should align staffing schedules, medication procurement, and laboratory capacity with anticipated seasonal demand. But monthly patterns are only part of the story. Patient attendance can also vary depending on the day of the week. To perform this analysis, we create another pivot table, drag the visit day into the rows area. We drag the patient ID into the values area and summarize using count. We insert a pivot chart and select a line chart. The analysis reveals that attendance remains relatively stable throughout the week. Tuesdays and Saturdays record the highest attendance levels, while Wednesdays record the lowest. Although the differences are not dramatic, they still provide useful operational insights. Hospitals frequently schedule staffings based on assumptions rather than evidence. This chart demonstrates how even simple analytics can support more informed scheduling decisions. Northbridge Hospital could use this information to ensure adequate staffing on higher volume days, while reserving lower volume periods for meetings, staff training, and administrative activities. At this stage, our OPT activity dashboard is complete. We have answered questions related to patient volume, service utilization, attendance trends, and patient retention. Together, these findings provide a comprehensive picture of outpatient department performance. But operational performance is only one dimension of healthcare analytics. The next dashboard shifts our focus from hospital activity to patient health characteristics. Anthropometric measurements provide valuable insight into nutritional status, chronic disease risk, and overall population health. Using our dataset, we analyze weight, height, BMI, and BMI categories to better understand the characteristics of patients attending the Northbridge Hospital. Let's begin with the weight. Before exploring nutritional indicators, we first need to understand the distribution of patient weights. To do this, we drag weight into values area 3 separate times. For the first field, open value field settings and select maximum. For the second field, select minimum, and for the third field, we select average. The results show a maximum weight of 120 kg, minimum weight of 84 kg, and average weight of 64.6 kg. At first glance, the average weight appears reasonable for a mixed patient population. To better understand the distribution of weight measurements, we need to visualize the data. To create this chart, we select the weight column and insert a histogram. We rename the chart titles with the distribution of weight, add axis titles, enable data labels if desired, and the histogram reveals how weight values are distributed across patient population. Most observations fall within the expected ranges, with fewer patients occupying the extreme ends of the distribution. Having explored weight, let's move on to another important anthropometric variable, which is the height. Using the same approach, we drag height into the values area 3 times and calculate the maximum, minimum, and average values. The analysis shows a maximum height of 1.9 meters, a minimum height of 0.5 meters, and an average height of 1.2 meters. Immediately, something appears unusual. While the maximum height falls within a realistic range, the average height remains unexpectedly low. This raises an important question. Is it simply because our dataset contains both adults and children, or could measurement errors be affecting the data? To investigate further, let's examine the height distribution. Insert a histogram using the height variable. The histogram reveals a substantial number of very short recorded heights. Some of these measurements may represent pediatric patients. However, others may reflect data entry errors or incorrect measurement techniques. Why does this matter? Because height plays a critical role in calculating BMI. Even a small error in height can dramatically distort BMI calculations. This brings us to one of the most revealing findings on the dashboard. The body mass index is one of the most widely used indicators of nutritional status and chronic disease risk. To summarize BMI, we drag the BMI field into the values area 3 times and calculate the maximum, minimum, and average values. The results show a maximum value of 476.8, a minimum of 2.41, and an average of 67.43. Rather than indicating a true obesity crisis, these results suggest that data quality issues are affecting the BMI calculations. Most likely, incorrect height measurements have inflated BMI values. To understand the extent of the problem, let's visualize the distribution. Insert a histogram using the BMI variable and rename the chart title to the distribution of BMI. The histogram reveals a strongly right-skewed distribution with several extreme outliers. This pattern confirms what we suspected from the summary statistics. A small number of unrealistic BMI values are disproportionately influencing the overall distribution. This demonstrates why data visualization is such a powerful analytical tool. Had we relied only on averages, we might have reached misleading conclusions. Fortunately, visual exploration helps us identify anomalies before making decisions. Despite these limitations, we can still explore the BMI categories to gain a broader understanding of nutritional status. To create this chart, we place the BMI category into the rows area, place the patient ID into the values area, and summarize using counts. Next, we right-click the values field and select Show As, the percentage of the grand total. Insert a column chart, rename the chart title to BMI categories, add data labels showing percentages, and hide unnecessary chart elements. The results show obesity in 63.4% of patients, underweight in 20.34%, normal weight in 9%, and overweight in approximately 7% of the patients. At first glance, this finding suggests a substantial burden of obesity. At the same time, approximately 1/5 of patients appear underweight. This phenomenon is commonly referred to as the double burden of malnutrition, where undernutrition and overnutrition coexist within the same population. However, because we previously identified significant BMI data quality concerns, these percentages should be interpreted cautiously. Before implementing large-scale interventions, the hospital should first improve anthropometric measurement practices and strengthen data validation procedures. Nonetheless, this dashboard highlights the importance of routinely monitoring nutritional indicators as part of population health management. Now that we have explored patient anthropometrics, let's turn our attention to physiological indicators that may reveal immediate clinical concerns. In this final dashboard, we'll analyze pulse rate, temperature, respiratory rate, and oxygen saturation to better understand the clinical profile of patients attending the Northbridge Hospital. Let's begin with the pulse rate. The first question we want to answer is, what proportion of patients present with normal or abnormal pulse rates? To perform this analysis, we create a pivot table, drag the pulse category into the rows area, drag patient ID into the values area, open value field settings and select count. Next, we right-click the values and choose Show Values as percentage of the grand total. This allows us to view the proportion of patients within each pulse category. Now we insert a pivot chart. The results show bradycardia in 6.5%, normal pulse in 54%, and tachycardia in approximately 39% of the patients. At first glance, this appears reassuring because more than half of the patients have a normal pulse rate. However, a closer look reveals that nearly 4 out of every 10 patients are tachycardic. Clinically, tachycardia can occur in a wide variety of conditions. Patients may present with fever, infection, dehydration, anemia, pain, anxiety, respiratory distress, or cardiovascular disease. A relatively high prevalence of tachycardia suggests that a substantial proportion of the patients are experiencing physiological stress at the time of presentation. For clinicians, this reinforces the importance of not overlooking pulse rate during triage. For hospital leadership, it highlights the need for standardized patient assessment protocols that ensure abnormal vital signs trigger further evaluation. The next question becomes, how common are abnormal temperature readings among our patients? To answer this question, we create another pivot table. Drag temperature category into the rows area, track the patient ID into the values area using counts, and display the values as percentages of the grand total. We then insert a column chart. The results reveal hyperthermia in approximately 70% of the patients, normal temperature in 28%, and hypothermia in about 1% of the patients. This is a striking finding, with nearly 70% of patients categorized as having elevated body temperature. Let's now investigate the respiratory status. Respiratory rate is one of the most important but frequently overlooked vital signs. In fact, studies have consistently shown that respiratory rate is often one of the earliest indicators of patient deterioration. This brings us to our next question. How common are abnormal respiratory rates among outpatient attendees? We create a pivot table, place the respiratory rate category into rows, place patient ID into values as count, convert the results to percentages of the grand total. We insert a column chart and rename the chart title to respiratory rate categories. Enable data labels and hide all pivot chart field buttons. The analysis reveals tachypnea in 69% of the population and normal respiratory rate in about 31% of the population. This means that approximately 7 out of every 10 patients are classified as tachypneic. That is a substantial proportion. If these measurements are accurate, the findings may indicate a considerable burden of respiratory illness among outpatient attendees. This highlights an important lesson in healthcare analytics. When results appear unusually high, analysis should investigate both clinical explanations and data quality explanations. Based on these findings, Northbridge Hospital should reinforce proper respiratory rate measurement techniques and conduct periodic audits to ensure data accuracy. We have already identified high rates of fever, tachycardia, and tachypnea. The logical next question is, how many patients are presenting with reduced oxygen saturation? The results show hypoxia in 61% and normal oxygen saturation in 38% of the patients. This is arguably the most concerning finding in the entire dashboard. According to the dataset, more than 60% of patients are classified as hypoxic. If this finding reflects reality, it would suggest a substantial burden of respiratory and cardiovascular disease amongst patients attending the outpatient department. However, such a high prevalence also raises important questions regarding data bodies. Analytics doesn't simply provide answers, it often raises new questions that require further investigation. Based on these findings, Northbridge Hospital should audit pulse oximetry performance, review oxygen saturation measurement protocols, verify data collection procedures. Now that we have completed all 3 dashboards, let's step back and look at the bigger picture. The OPD activity dashboard showed us that outpatient attendance is increasing and that most patients visit the hospital only once. This suggests growing demand for services but also highlights opportunities to strengthen continuity of care. The Anthropometrics dashboard reveals several important nutritional trends. And finally, the Vital Signs dashboard identifies a high prevalence of abnormal physiologic measurements that may reflect both disease burden and opportunities to improve measurement practices. Taken together, these findings demonstrate why healthcare analytics is so powerful. The goal isn't simply to create charts, the goal is to transform routine healthcare data into actionable insights. Based on the findings from all 3 dashboards, several recommendations emerge. The visits per patient ratio suggests that many patients attend only once. For chronic conditions, continuity of care is essential. Northbridge Hospital should implement structured follow-up systems, appointment reminders, and chronic disease clinics. Secondly, using attendance trends for resource planning. Patient attendance increased between 2024 and 2025. Hospital leadership should use these trends to guide workforce planning, medication procurement, and infrastructure expansion. Thirdly, improve data quality processes. The anthropometric analysis identified unrealistic BMI values driven by questionable height measurements. The hospital should implement validation rules within the hospital information system and conduct routine data quality audits. Next, strengthening nutritional assessment programs. Despite data quality concerns, the BMI dashboard suggests a potential burden of both undernutrition and obesity. Routine nutritional screening and counseling services should be strengthened. The high prevalence of hyperthermia suggests that infectious diseases represent a major component of outpatient presentations. The hospital should maintain strong surveillance systems and ensure adequate diagnostic and treatment capacity. Audit vital sign measurement practices. The high prevalence of tachypnea and hypoxia warrants further investigation. Regular staff training, equipment maintenance, and measurement audits should be conducted to ensure accurate data collection. Implement early warning systems. Patients presenting with abnormal vital signs should be identified rapidly and prioritized for clinical review. Simple outpatient early warning systems can improve patient safety and reduce misdeterioration. Build a culture of data-driven decision-making. Perhaps the most important recommendation of all is to integrate healthcare analytics into routine hospital operations. Data should not be collected simply for reporting purposes. It should be used to identify problems, monitor performance, evaluate interventions, and support continuous improvement.